My name is Juanita Merchant, and I am currently Chief of Gastroenterology and Hepatology at the University of Arizona in Tucson, and I will be presenting highlights from the top AGA abstracts for this Best of DDW symposia. The abstract is from Johns Hopkins, lead author Nicholas Zakos, focused on NHE3 is a drug target for treating diarrhea. The morbidity and mortality of acute diarrhea is due to abnormal regulation of ion and water transport across the intestinal epithelium, leading to significant dehydration. The sodium hydrogen exchanger, or NHE3, accounts for electroneutral sodium absorption that occurs during digestion. In most diarrheal diseases, there is inhibition of neutral sodium chloride absorption in the sodium absorptive cell, primarily due to NHE3 inhibition. The NHE is regulated by a multi-protein signaling complex that forms on its C-terminus. Pay particular attention to the inhibitory regulatory complex, which shuts down NHE activity. The authors developed an NHE3 C-terminal peptide mimetic that was fluorescently tagged such that it will bind to the inhibitory regulatory complex, and under physiologic and pathophysiologic conditions can stimulate the NH3 activity. Using a mouse model of acute diarrhea using cholera toxin or even E. coli heat-stable toxin, they treated the mice with the NH3 C-terminal mimetic. Shown in this slide is the essential result of their study, in which the peptidomimetic N3SP1 inhibited the accumulation of fluid in the mouse jejunum in vivo, and that is quantified on the right-hand portion of the slide, showing that in the presence of N3SP1, there is a block of the accumulation of fluid in the small intestine. So in conclusion, the N3SP1 peptide mimetic stimulates basal and prevents acute inhibition of NH3 activity by cyclic AMP, cyclic GMP, and calcium, and suggests that a NH3 mimicking peptide might be used to develop drug treatment for diarrhea. The peptide was delivered by nanoparticles, which is useful in developing the treatment for diarrhea. And the mechanism responsible for N3SP-mediated reduction of intestinal fluid secretion, in addition to NH3 stimulation, needs further evaluation. The next presentation is Metaplasia-Induced Epithelial Heterogeneity Directs Pancreatic Tissue Injury and Recovery by Kathleen Del Giorno at Vanderbilt University. Pancreatic cancer is the third leading cause of cancer death worldwide, and the 5-year survival rate is only about 10%. KRAS is the most frequent mutation found in pancreatic cancer. The term metaplasia is the substitution of one cell type for another. Another way of thinking about it is that it's a normal cell in the wrong place. It has been described as a single-step developmental reversion. Examples of metaplasia are seen in Barrett's esophagus as well as gastric metaplasia, particularly intestinal metaplasia, or the spasmolytic polypeptide expressing metaplasia, also found in the stomach. In this study, the authors proposed that the normal acinus during injury can transition between a metaplastic state or a dysplastic state. And once dysplasia develops, this is one of the precursor lesions on the way to adenocarcinoma. The authors use a combination of lineage tracing and single-cell RNA sequencing to identify the different populations within acinar ductal metaplasia. An example of that heterogeneity typified by the appearance of these tuft cells, shown here highlighted with phalloidin in orange, with the little tuft at the apical surface of the acinus, is shown here. The key conclusions of their study is that the acinar reprogramming in response to chronic injury or oncogenic mutation results in substantial epithelial heterogeneity. That acinar ductal metaplasia is like the type of metaplasia observed in the stomach, also known as pyloric type of transition. ADM, or acinoductal metaplasia, generates multiple enteroendocrine cell types. What do the role of ADM-derived cell types play in pancreatic injury, regeneration, and tumorigenesis is going to be the focus of future studies. Thank you. The next presentation, entitled COVID-19 and the Gut in Human Obesity, was presented by Alison McRae from a group at Mayo Clinic. Cell entry into the enterocyte is mediated by two mechanisms: viral binding, the receptor being angiotensin converting enzyme 2, and by host viral fusion mediated by three proteases: transmembrane serine protease 2, furin, and cathepsin L. Patients with COVID-19 have well-documented GI complications. There is almost 18% prevalence of COVID-19. 16% of COVID-19 cases only present with GI symptoms, and 61% of hospitalized COVID-19 cases present with GI symptoms. Expression of viral entry factors ACE2, TMPRSS2, and cathepsin L have been detected along the human GI tract, including stomach, ileal, and colonic mucosa. Clinical evidence now supports the GI tract, in addition to the respiratory system, as the potential route for SARS-CoV-2 infection. Obesity is a recognized risk factor for severe illness and death from COVID-19. Obesity, a BMI of greater than 30, and those overweight individuals represent 73% of hospital COVID deaths. It is unclear whether the gut mechanisms in obesity predispose to increased susceptibility to SARS-CoV-2. So the authors asked the question, are patients with obesity more susceptible to SARS-CoV-2 infection by virtue of enhanced cell type specific expression of the SARS-CoV-2 entry cofactors in the gut? The aim of the study was to determine cell-specific alterations in expression of COVID-19 entry factors by single-cell RNA sequencing of human colonic mucosa in obesity compared to the lean control. The results of their study showed that both in the discovery single-cell sequencing RNA-seq analysis as well as the validation group, that the protease TMPRSS2 was overexpressed in colonic tissue from obese patients compared to lean patients. Shown here on the right-hand portion of the slide is not only the protein analysis, but also the immunohistochemistry showing higher levels of this protease in the colonic tissue from obese patients. So key summary points are that the digestive system may serve as a portal for infection by SARS-CoV-2. Characterization of cell type specific expression of COVID-19 protein entry factors in the human gut. In obesity, intestinal TMPRSS2 is elevated at the mRNA and protein level. Overexpression of SARS-CoV-2 entry factors may play a role in increased initial susceptibility to COVID-19 and worse disease outcomes in human obesity. Further studies are needed to understand the cell-specific role of the GI mucosa and COVID-19 in patients with obesity. The physiological consequences of goblet cell overexpression of TMPRSS2 in obesity may be with COVID-19. This next study from the Imperial College in London, led by Benjamin Mullish, looks at daily probiotic use associated with reduced upper respiratory tract symptoms in overweight and obese people. Respiratory tract infections represent a significant global burden of disease, and at particular risk are those that are obese or overweight, as well as older people. So currently, there are limited strategies to prevent upper respiratory tract. So the gut-lung axis appears to be a likely contributor and participates in the bidirectional interactions between the gut microbiome, the gut barrier function, and immune inflammatory cytokine responses. Therefore, the question is whether the manipulation of the gut microbiome is an important therapeutic target in the treatment of upper respiratory infections. So the study design was a single-center, double-blind, placebo-controlled, randomized controlled trial in which 220 participants with a basal metabolic rate consistent with obesity and between the ages of 30 and 65 years of age. They were randomized either to a probiotic arm in which 50 billion colony-forming units were used or an oral capsule. There were no dietary or lifestyle changes. The results shown here demonstrated that there was a 27% reduction in upper respiratory tract symptoms in the probiotic versus the placebo group, especially in those over the age of 45 and with a BMI greater than 30. So in summary, the lab 4P probiotics are associated with improvements in weight and metabolism, reduced symptoms of upper respiratory infection, especially those that are older or obese, and this occurs within a short duration of use. So there is the potential for probiotic-mediated stabilization of the gut microbiome and an association with upper respiratory tract infections. There may be more roles for probiotics in the prevention or reduction of the incidence of upper respiratory tract infections, especially in adults that are in the high-risk group. The next study is from Sinead Buell from Denmark. The title of her study is Discontinuation of Infliximab Therapy in Patients with Crohn's Disease in Sustained Combined Clinical, Biochemical, and Endoscopic Remission. The experimental design shown here is a double-blinded, placebo-controlled, Nordic multi-center randomized clinical trial in which patients with a CDAI score of less than 150, no endoscopic or MRI signs of active disease, and normal biochemical parameters were randomized either to continuation of infliximab with an unchanged dose or discontinuation of infliximab therapy and placed on placebo. The endpoints were reviewed at 48 weeks. Remarkably, over the 48 weeks, 96% of those that remained on infliximab stayed in remission, whereas only 49% that were on the placebo group remained in remission. So the key takeaways from this study are that after 1 year, clinical relapse-free survival was 51% in the placebo group and 100% in the infliximab group. Patients receiving immunosuppressant therapy tended to show lower risk of relapse, although the study was not powered to detect a difference. There was a combined clinical and endoscopic remission was maintained in 87% of patients continuing on infliximab and 31% of those discontinuing infliximab. So in conclusion, even in patients in combined clinical, biochemical, and endoscopic remission, discontinuation of infliximab leads to a considerable risk of relapse. The presentation is from Nicole Rich from UT Southwestern on racial and ethnic disparities in survival among patients with hepatocellular carcinoma in the U.S., a systemic review and meta-analysis. HCC is the fastest rising cause of cancer death in the U.S. However, HCC incidence and mortality are not equally distributed among racial and ethnic groups. Data are conflicting on the magnitude and direction of disparities in overall survival. The overall aim for this study was to characterize the direction and magnitude of racial and ethnic disparities in HCC prognosis, using study outcomes of overall survival and early stage. The study characteristics included a diverse study population in which there was 17% Black, 18% Hispanic, 5% Asian, and HCV was the most common etiology of HCC. The definition of early stage hepatocellular carcinoma used a variety of criteria, and the study cohorts were both academic and population-based. Since this was a retrospective study, there were certain limitations. All studies were retrospective, missing data, measurement bias, potential misclassifications of race and ethnicity, and selection bias. There were administrative data sets used less clinically relevant staging systems for HCC, lacked data on cirrhosis etiology, liver disease severity, and treatments beyond the first HCC treatment. And most studies controlled for tumor stage or treatment receipt. Fewer adjusted for liver disease severity. Since race is a social construct, few studies attempted to identify root causes driving HCC disparities, and no studies to date perform multi-level or formal mediation analyses to identify factors mediating racial ethnic disparities in prognosis. The major finding was that Black patients with HCC had a worse overall survival compared to white patients. The subgroup analyses for overall survival in Black versus white in 7 out of 17 studies showed an odds ratio of 1.12. However, the odds ratios for Hispanic versus white and Asian versus white were less than 1.